Hello and welcome to today's webinar event. I'm Carol Flagg of Answers Media Network. Thanks for joining us on this continuing series of webinars with EFAX Corporate, which is part of J2 Global. Today we're focused on the HHS proposed rule revising HIPAA privacy. Our two speakers today are no strangers to our thought leader events. Lee Barrett is the CEO and Executive Director of the Electronic Healthcare Network Accreditation Commission, better known in the industry as ENAC. Lee's work includes advancing key initiatives in health IT, and he speaks nationally on healthcare legislative mandates and implementation. He was appointed by the previous national coordinator, Don Rucker, as FAST co-lead of the Testing and Certification Tiger team, and he also serves as a member of a number of leading organizations in health IT, including HSS, the Healthcare Sector Cybersecurity Council, the HIE Leadership Council, and the Sequoia Project. Joining Lee is Brad Spanbauer, who oversees J2's professional services. His focus in healthcare led to his role at J2, where he serves as the company's HIPAA privacy and compliance officer. Brad not only is a regular presenter on all things HIPAA for these webinar events, he presents and speaks nationally at leading conferences. On today's webinar, we'll begin with an overview and timeline of the proposed rule. We'll also give an update from OCR on COVID. Then we'll take a look at the various major components of the proposed rule, what to expect under the new administration, a quick look at the safe harbor law, and finally, what CEs can do now to prepare for the release of the final rule. And now I'm going to turn today's presentation over to Brad and Lee, and I'll be back with you guys on the Q&A.
Thank you, Carol. As Carol mentioned, we're going to be covering the proposed changes to the HIPAA privacy rule. It really breaks down into a couple of categories. One would be strengthening the individual's right to accessing their own health information. It'll also modify how information is shared for care coordination and case management. And it'll facilitate greater caregiving involvement for emergencies and health crises, whether that be between care providers or even family members. And it will reduce, hopefully, some administrative burdens for covered entities and health plans while continuing to provide its privacy or meet its privacy mandate. So the timeline of the rule, it came out actually in December of last year. And the notice of proposed rulemaking was published in the Federal Register, open for comments, and that will close on March 22nd. So hopefully, if you're listening to this coming out of it, you'll go and add your comments. Usually, it takes about 90 days after the close of comments for rules to really take. And then covered entities will have 180 days to implement whatever comes out of the changes. Lee, if you'd like to talk about our code.
Thank you, Brad. And Carol, thanks very much. So here's what I wanted to do here in a few of these slides. And, as Brad kind of went over, what the certainly the privacy MPRM rule is and the timeline. You've gotten kind of an overview of kind of what that's going to be as far as a timeline. We're going to get into a lot more depth on it as we go forward. But some of what has happened here with this privacy rule really goes back to the pandemic when it started. And really what happened is the Office for Civil Rights, what you're going to see here, it came out with a bulletin, and several bulletins actually, and guidance to the industry when the pandemic actually started back in February of 2020. And this, what you're going to see is some really important and kind of themes that you'll see throughout the privacy MPRM as well that came out of some of this guidance that OCR provided to the industry, to business associates as well as to covered entities. The focus that you're going to see here as we go through some of these slides in what they provided as far as guidance to the industry really focused on trying to minimize the impact on certainly the fines and penalties that could be levied by OCR throughout this. The objective was really to increase the amount of information sharing amongst a variety of entities, and you'll see that. And then the other aspect you're going to see through a number of these was really to focus on good faith efforts of all the various, not only covered entities, but business associates on how they would deal, how they would exchange information having to do with patients. So this particular set of bulletins here really focused, as I said, on treatment, public health activities, family, friends, and really the individual care coordinators themselves as far as payment for care, cautions against disclosures to the media, and again, the whole minimum necessary component, which, and you'll see that throughout many of these, they continue to remind organizations about how much and what information should or should not be disclosed. Next slide, Carol. So as you'll see when they started to talk about and the whole telehealth component here, and as we all know, telehealth really became a key communication vehicle between patients and providers during this pandemic. And so what they were doing as far as OCR, again, was focusing on the fact that they were not impose HIPAA penalties against covered healthcare providers for non-compliance. Again, focusing on good faith provisions of telehealth and using remote communications technologies. We'll talk a little bit more in a second about what entities fell under that. Also, it had to do with the fact that it was applying to telehealth for any reason for diagnosis or treatment, and would not be limited to just COVID-19, but for any other issue that a patient had. So we were starting to see, as many of you are aware, telehealth was becoming a key component since patients weren't going into provider offices. Now, what they indicated here is what types of apps could and could not be used for this communication. So applications such as FaceTime or Skype could be used, but Facebook Live or Twitch or TikTok could not be used. So they were, again, concerned about some of the security aspects that were part of this, and so they limited which communication apps, telehealth apps could be used for this linkage between organizations. And they would not impose penalties for the lack of a BAA with video communication vendors. So again, trying to make this as easy as possible for the providers and for patients to continue with whatever diagnosis or whatever issues that treatment plans that people already had, along with COVID as well. Next slide, Carol. Then we go on from here again to additional kind of the telehealth remote communications, and again that guidance again focusing on what covered entities are included and excluded, which parts of the HIPAA rules would be included in the notification, the fact that the notification applies to violations of 42 CFR Part 2, and it protected the overall confidentiality of substance use disorder on patient records, and kind of where can covered healthcare entities conduct telehealth. And so they provided the guidance on how to do it, because a lot of this is obviously non-public facing, and they may be using a remote communication product as well. Next slide. As we go on with some of the guidance that they continued to provide here, this particular guidance focuses on law enforcement, first responders, as well as public health authorities. And again, this was focusing on the privacy rule permissions and provided some examples of when a covered entity could disclose PHI about individuals without their authorization. And so they focused on things like when the disclosure is needed to provide treatment, when the disclosure is required by law, notification of a health authority, public health authority, to prevent the control or spread of, in this case, COVID-19. Also to protect first responders and when they're at risk of infection, and that information again could be disclosed. And again, serious and imminent threat. So the whole aspect, again, and you're starting to see some themes through this, also focuses on the reminder to BAs as well as covered entities on assuring that only the minimum necessary standard is applied and used throughout this, so that organizations are not, and individuals are not disclosing any more information than is absolutely necessary. Next slide. Then, we start to talk about the BA uses and disclosures for public health and health oversight. And this focuses on the whole aspect of disclosure of information to public health authorities and health oversight agencies, state and local health departments, and state and emergency operations who needed access to COVID-19 related data. This focuses again on the fact that OCR was going to not impose HIPAA penalties against healthcare providers or their business associates for good faith uses and disclosures of PHI. So the objective here, and you can see this, how this basically goes over into the privacy MPRM as well, and provides some of the key provisions that are part of that, as far as what they did as far as these bulletins. And so the privacy rule already permits covered entities, in this case, to provide data, and the enforcement discretion permits business associates to also share the data without any risk of HIPAA penalty. And so the focus was creating this environment for certainly healthcare as COVID and the pandemic hit, to be able to provide this information as much as possible, again, trying to keep it under the minimum necessary rule. Next slide. And so then the other entity that was part of this is the whole aspect of community-based testing sites. And so as more of these testing sites were in fact promulgating, OCR would again not impose HIPAA penalties against these providers with good faith participation. And really it's these testing sites and collection of specimens, again, from individuals, would not be subject to any penalties. They'd be able to share the data with the appropriate agencies. Reasonable safeguards would be taken to protect the PHI. And there were different examples that they also provided that are not covered under the notification. But again, they were trying to provide and promote as much sharing of information, especially with various agencies and entities, and trying to provide the ability for caregivers, for patients, to be able to gain access to some of this data and information as well, and be sharing it with the appropriate entities. So all of this is really about information sharing and protecting information as much as possible, but encouraging more information sharing and trying to limit penalties and any type of implications that OCR may impose on covered entities or business associates. Next slide. Turn it over to you, Brad.
All right, well, staying on that theme of sharing data, they've made some modifications to an individual's rights around accessing their PHI. Number one, if you make a request to get your records, that has been a 30-day respond no later than time for providers. That's been reduced to 15 calendar days. And the extension, if they needed one, is reduced from 30 to 15 days. So that makes it easier if you need to get your healthcare records. It also allows for the sharing of PHI across electronic health record systems when it's requested by an individual. So it makes it easier for you if you're seeing, or it makes it easier for an individual if they're visiting a healthcare provider to have that healthcare provider help them share their records with other providers, so they can share the PHI across EHRs. It also provides some clarifying language on being able to access your own records via electronic means as an individual, opening that up a little bit more, and also reducing the burden around identity verification when it comes to accessing your records or sharing them. It also requires that covered entities provide a fee schedule for access and for getting information shared, making that more visible to the end user.
So this particular aspect of the proposed rule really amends the definition of healthcare operations to clarify that it includes individual level care coordination and case management. Some had interpreted the current definition as limiting a health plan's ability to perform care coordination and case management to population level activities only. The proposed change, would make clear that health plans may also provide individual level care coordination and case management as part of their healthcare operations. The MPRM additionally clarifies that covered entities may disclose PHI to social services agencies, community-based organizations, home and community-based service providers, and other similar third parties that provide individual level care coordination and case management activities, even if the entities are not healthcare providers and or are not covered by HIPAA. So that's really what this particular provision here from a further clarification includes. Brad, over to you.
All right, we're going to carry on with some modifications to the rules. As you see here, covered entities don't have the same minimum necessary requirements for disclosure between the healthcare providers when it comes to case management activities, especially when those activities are part of treatment or healthcare operations. It also loosens up requirements on sharing PHI through social services or home health care, community-based service providers when they're providing treatment. And they don't necessarily need to have a patient authorization to share that information if it benefits the person who's getting the treatment. And it allows for more broad sharing of patient information when it comes to substance abuse or mental illness or other social emergencies.
Next slide. So under this particular provision of the rule, the MPRM would allow covered entities to disclose PHI to avert a threat to health or safety when a harm is serious and reasonably foreseeable. Instead of the current stricter standard, which requires a serious and imminent threat to health or safety, OCR states that it is proposing the change to avoid situations in which covered entities decline to share PHI that they believe could prevent harm because they cannot determine how imminent the threat is, and therefore whether the disclosure is permitted under the privacy rule. So that's what this particular provision is focused on. Brad, over to you.
All right. So in addition, the proposed rule changes modify requirements around a patient's acknowledgement of NPP. It eliminates some of the requirements around covered entities having to obtain written acknowledgement or a receipt of the privacy practices, which really helps eliminate some of that administrative burden on a covered entity. It also eliminates some confusion for patients as to whether or not they're entering into a contract or if they might be waiving their rights to privacy. It also allows for some clarification so that individuals know how they can access their data and how to file a HIPAA complaint. It also helps them understand how to receive a copy of the new requirements. It also helps them specify whether the contact person they need to work with is on site and how they might get in contact with them. And it also changes how an individual can obtain a copy of the records at a limited cost or perhaps free of charge. And it also allows the CE to transmit electronic copies of PHI and records to a third party over an EHR. So there's also some modifications around telecommunications relay services. So this alleviates the burden on these services when it comes to providing or supporting healthcare services over a relay service. So if somebody is deaf or hard of hearing and they need support, covered entities will be able to use these services without the burden of going through a cumbersome BAA process. Next slide.
So thanks, Brad. Let me take a few minutes to talk about some of the changes that are going on under the new Biden administration in this first 100 days of his administration. So the newly designated head of the Office of National Coordinator is Mickey Tripathi. And Mickey, many of us have known in the industry, is really a terrific individual as far as all of the work that he has done in interoperability. He is former CEO of the Massachusetts eHealth Collaborative, been on the board of directors for Sequoia. He's also been leading the Argonaut project, which again is a fire initiative, developing different use cases for fire as the API in support of interoperability. So many of us who have known him for many years are thrilled that Mickey is in this role, and we really all look forward to working with him. The CMS administrators from the former Obama administration, Brooks LeSueur, and again, looking forward to the changes that will be occurring there. There's some others that I'll share with you that are going through the process, nomination process. Xavier Becerra, who is the nominee for HHS Secretary, is California Attorney General, most recently led the California's defense of the ACA before the Supreme Court, and he was a former congressman and chairman of the House Democratic Caucus. Andrea Palm is a nominee for the HHS Deputy Secretary, designated Secretary of the Wisconsin Department of Health Services, and former Assistant Secretary of HHS during the Obama administration. Rachel Levine is also a nominee for the Assistant Secretary for Health. She's been the Pennsylvania Secretary of Health. She's a pediatrician and professor of pediatrics and psychiatry at the Penn State College of Medicine. And then there are a number of others as well. For example, the CDC director is Rochelle Walensky. She's Chief of Infectious Disease Division at Massachusetts General Hospital and Professor of Medicine at Harvard Medical School. Many of you are already familiar with Tony Fauci, as Chief Medical Advisor, former Director of NIH, National Institute of Allergy and Infectious Diseases. So there's some very excellent people that are not only going through the nomination process, but have already been named in some of these key roles. As far as 21st century cures and interoperability, a couple of things we see occurring here. First of all, with the designation of Mickey Tripathi for ONC head, we feel, and all indications are, that a lot of the work that's gone on with 21st century cures, and we know that there's some additional work that's going on in the legislature regarding Cures 2.0, even at this point, that a lot of those interoperability initiatives will continue on, is what we're hearing with this administration, and that a lot of these actually started, 21st century cures to begin with, actually started under the Obama administration. So it's felt that those will continue, and in fact, when that was passed, it was passed by bipartisan support for it. So we feel that a lot of these initiatives, whether it's 21st century cures, and TEFCA, the Trust Exchange Framework with Common Agreement, the information blocking rule that many of you are familiar with, that's going to be moving forward to implementation in the next year and 2 years. The Fire at Scale Task Force Initiative, which again focuses on the promulgation of FHIR as the API standard from Health Level 7 for application program interfaces, and Sequoia, who's the designated recognized coordinating entity, and all the work that they've been doing over the past basically year and a half here since they were designated by ONC as the RCE on the work that they're doing on the common agreement. All is expected to continue to move forward. And in fact, we're thinking that we'll see a draft of the common agreement perhaps by the second quarter of 2021. So a lot is continuing to go on. We expect that it will, as far as all of this, and obviously HIPAA, this new privacy MPRM as well, will all be taken into consideration in a lot of the work that is going on as we continue to move these agendas forward, especially the whole fact that we're trying to set up these qualified health information networks as part of TEFCA, and participants. A major underlying theme throughout all of this for patients and for all the various entities is around privacy and security. So a very significant one there. There's a new law that as well was signed by then President Trump before he left office on January 5th. And this particular law, which is called HR 7898, or the Public Law 116-321, is commonly referred to as the HIPAA Safe Harbor Law. This is also, I think, an important consideration for all of you to be aware of, that this really amends the HIPAA HITECH Act and requires Health and Human Services to focus on incentivizing organizations to promulgate best practice security. And this all has to do with trying to not penalize those organizations that might have been impacted by a cyber attack, ransomware or otherwise. And so what's happened previously is that some of these organizations that had a cyber attack not only were going through their own issues of dealing with implications as far as credibility, how that may have impacted their revenue, a number of impacts these organizations went through. But then they could be subject to an audit by the Office for Civil Rights and be subject to additional fines or penalties because they didn't do certain things or have their, quote, cyber hygiene in place. So what this is doing is really incentivizing organizations to, in fact, move forward and have their their cyber infrastructures reviewed and to go through a third-party entity, whether or not it's ENACS accreditation or high trust certification as examples, to meet what are called recognized security practices. And as long as an organization can demonstrate over the past 12 months that they've gone through this third-party entity, and again, all of this has to be under the auspices of the National Institute of Standards and Technology, NIST requirements, as well as the Cybersecurity Act of 2015, which is the 405D, are named specifically in this law. It really does incentivize organizations to go through these third-party reviews and be less subject to any type of audit or penalties that OCR may look to impose, which they have imposed previously, so that organizations hopefully will look to up their game on going through these and assuring that they're applying with the best practices. So all of this hopefully will help to incentivize organizations to move forward with their risk mitigation in relation to cyber. Next slide, Carol. So I guess the question that we wanted to leave you with here before we get into the Q&A is, so what can covered entities do now to begin preparing for the final rule? So I think Brad and I have got a couple of ideas for you that we want to leave you with. First, I would say that, as a result of looking at all of these, we would tell you to be reviewing your policies and procedures and determining, what revisions you may need to make to any of those policies, those procedures that you have, and start making provisions on what those revisions may be. The second aspect, I would say, is as well around training, to look at where you're going to need to make any changes to your training for your staff on these various changes, because all of this really focuses on providing more access for patients to their protected health information as we've reviewed here with you. And so, the front office, I think, in your organizations and covered entities are going to need to be aware of the fact that there may be certain forms that patients have previously done and submitted where those procedures need to change. The fact that a patient could come in and say, I'd like to review my PHI right here. And so the front office staff needs to be prepared on how to do that, as well as the timing for if a patient asks for their record to be sent to some other entity. Again, the timing is going to go from 30 days, which was what was in the law up to this point. If this is implemented, it now goes to 15 days. So all of this from a timing perspective on, I think, the training of staff, revisions to policies and procedures are things that all of the entities need to be aware of, be thinking about, if in fact this rule goes forward and is approved. Brad, any thoughts that you have?
Yeah, I would say the thing to understand is a majority of these changes really will help eliminate some burden for covered entities. So we provided some links throughout the presentation that you'll have where you can go read on the HHS site and some of the documents they have. There are some nice summaries there explaining what you need to do. And in the end, if you're ready to implement these, when it goes through, you'll see a reduction in your burden. There are some things you have to do to provide easier access to patients, but in the end, that'll make your life easier. So I would really encourage, unlike other, I would say, policy changes that sometimes feel like a greater burden, these are helpful changes. So embrace them. It'll make your life a little bit easier, and it'll help support patient care. So the patients will appreciate it as well.
All right. Well, and with that, we're going to be taking some questions from our audience. We've already got quite a few questions queued up. We're unlikely to get to all of these questions, but fear not. The questions, if we don't get to them, they will be addressed offline. So, Brad and Lee, we've got about 20 minutes here, so I'm just going to start right in. So how does the federal rule impact state privacy rules such as CCPA?
So I'll start, as far as kind of the CCPA, basically, and you look at this, basically HIPAA and the MPRM here for privacy really are floor preemptions. State laws, may set stricter standards. However, CCPA in its text really defers HIPAA for PHI. So California standards are the same as HIPAA for PHI, but California is stricter in relation to protected identifiable information, so PII. So when you look at CCPA as an example, Carol, here, the personal data means information that identifies, relates to, describes, is reasonably capable of being associated with, or could reasonably be linked directly or indirectly to a natural person. Where PHI is identified or identifiable to a person, but does not go as far as associated with linked, which we interpret as metadata. So the bottom line is what we're thinking is that although this certainly is the rule here, the MPRM starts to set kind of that floor preemption, the CCPA as well as the General Data Protection Regulation, which CCPA is built upon, is and probably are going to be perceived as stricter. And we're seeing a number of other states as well that are looking at adopting similar legislation as that of CCPA. And in fact, there's continued discussion even in Congress about taking this even further to adopt very similarly what CCPA and some of the state laws will do as far as becoming stricter. So that's kind of the answer to hopefully the question that's been posed. Brad, I don't know if you have anything else to add.
That was a great explanation.
Well, I think it's probably worth noting too that what California did is really based on what Europe did with GDPR, and so there is a lot of, Lee, as you said, a lot of interest by other states to adopt more stringent privacy legislation. All right, any guidance on how as a medical practice we can best future-proof for further HIPAA changes or other future privacy rules?
Well, future-proofing, admirable thought, tough to execute. I would say, from a selfish standpoint, make sure that whatever partners you have in your medical records, EHR, EMR space, that they are competent and they are looking towards what might be coming down the pike. If you are using applications and services that focus on maintaining compliance, then all you really have to worry about are those administrative sort of people-facing regulations, and those are much easier for you to change. You have direct control over them. So if you're concerned about rules and regulations changing about moving data around, let your technology partners worry about that for you. Just be confident in who they are, and then you can again sort of focus on your day-to-day administrative policy. Lee?
Good answer. I have nothing else to add there.
If a patient puts restrictions on certain information keenly relevant to their coordination of care, and I as a provider, I accept, any issues with information blocking here with third parties that may also be involved with that care?
I think the real issue here, Carol, and Brad, I'm sure you've got a perspective, but it is if it relates to treatment, payment, or operations, yes, patient has the right to put certain restrictions on, and it depends upon the level of restrictions they want to put on. Yeah, as far as their information, I mean, if they can certainly easily restrict who has access to their records as far as individuals in that that they want, whether in their household or relatives or whatever, they have every right to do such a thing. But as far as information that has to do with their treatment, the payment by a health plan, and well as other entities that may have need to have access to the information, such as state agencies or whatever, based upon if it's a health issue related to COVID or something else that health departments are looking to track, then that information is not going to be able to be, quote, restricted. So that's the issue. There are aspects here that I think entities are going to have to be aware of what restrictions that a patient certainly has every right to put on versus those that they can't, and especially if related to treatment, payment or healthcare operations is really where I think the issue is. So that's where I think organizations are going to need to be very well aware of what is and what is not within the realm of a patient to restrict. Brad, anything else?
I think you nailed it. It's those personal, you have greater control of, or the patient does, over those personal relationships versus the business or governmental relationships and sharing data there. So
Yeah.
you hit the nail on the head.
Yeah. Should organizations, and Lee, you touched upon this actually in the presentation, should organizations continue to expect more refinements to privacy rules as the Cures Act, TEFCA, and interoperability architecture is implemented over the next few years?
So I think the answer is going to be what's going to be happening, and for any of the providers that are listening to the webinar here and participating, what's going to happen is that these application program interfaces, these APIs that are being developed, and again, FHIR is going to be and is the standard that will be used for these application program interfaces. Developers are now focusing on developing all of these APIs. Many of you already are using APIs. Take your smartphones. You look at any of the apps that you have in your smartphones. Those are all being started when you click on them by APIs. So within healthcare, there's a lot of APIs that are already being used today. For example, with payer and provider portals that patients are using and others are accessing information. So what I can tell you is that the promulgation of APIs on with electronic health record systems, with portals, with access to information, the whole aspect of APIs really becomes a foundational component for interoperability. And as we start to implement the Trust Exchange Framework with Common Agreement, TEFCA, and we start to implement this quote healthcare digital highway with qualified health information networks, participants, and all the various stakeholders that are going to be exchanging data with all these various entities, APIs, as far as whether it's provider, patients, is going to become the way in which interoperability is going to occur, and how we look to increase the amount of exchange of information and break down the barriers of not being able to access information because one system doesn't talk to another or one application doesn't talk to another. So this really levels the playing field on data exchange and will increase the amount and the capability for data exchange, hopefully then reducing all of the cost that goes into this and for maintaining all these various interfaces. Because if you look into in hospital systems, many hospital systems I've looked at over the years have like even 150 different interfaces just to maintain all the various connections between systems. It's very costly, very time consuming, and basically subject to really a lot of information exchange not occurring. So really this is really going to be the way in which this architecture looks to get implemented, and APIs are going to be really the key foundational component for all of that to occur.
That sort of segue.
Brad, anything else you would add?
Again, very thorough. My comment for anybody who might have to think about APIs. Normally, a healthcare provider is not thinking about APIs; they're thinking about patient care, and it's those folks who manage data who think about how do they move it around. Code to those standards. HL7 and FHIR have been around for a while. The standards exist. There's no reason for people not to be developing today to share data openly. We all understand how it needs to be shared, what needs to be shared. You shouldn't have to be pushed to do it. So, yeah.
Segueing to the next question, do you think the final rule will require providers to implement APIs? And if that's the case, do you think there'll be like a cost threshold?
Well, that's interesting. Again, it's I don't think that providers think about implementing APIs. I think they, again, think about patient care and what's the most efficient way to provide that. It's your technology providers that will be worrying about, thinking about implementing APIs that are hopefully easily shared and always compliant, always compatible.
Well, believe it or not, we've just got a few minutes left here, so I'd like to, pose a question of my own, which is any final thoughts from each of you about the MPRM, and of course, what may even happen as the rule finalizes later in the year.
Well, I think that what we're seeing here is a goal to alleviate burden across the board, whether that be allowing for telehealth, whether that be if you're compliant, not penalizing people who might be the victim of a security breach if you're following the rules, and bad actors get in. There's less of a feel for punishment and more of a feeling of support from HHS. So alleviating burden, more of a partnership in providing patient care. That's what this new rule feels like to me.
I think the only other thing, only a couple of other points to make is that, as Brad was talking about, certainly the minimizing burden is a key part of this. Another is, as you're seeing the theme here, is to provide patients with greater access to their information. And really that's a major focus of interoperability and 21st century cures. It is really all about increasing the ability for patients to have greater access to their information and to promulgate as well more data exchange and really the implementation of this digital highway that we're seeing starting to implement. I think the other aspect of this, which is important, and we started, as we start to look at the NPRM, and you talk about privacy and security. Privacy and security are foundations here. Throughout all of this is really about protecting patient information, patients having more control over their data, and putting in the appropriate levels of policies, procedures, and controls over patient data exchange and who has access to that. And so, as we look at this and this NPRM, it starts to continue to put some greater controls around privacy and how data is exchanged. We're continuing to see, I think, and will continue to see, as whether some of the state laws as well, like the California Consumer Protection Act and others, the General Data Protection Regulation, we're continuing to see greater scrutiny around privacy, and will continue to do so, I believe, because it's really all about assuring privacy of this information, certainly for patients, and as much as possible, making it easier from the aspect of kind of treatment, payment, and operations to be able to get at this information and exchanging data. As this pandemic has proven, we need to be able to provide data to healthcare agencies and others.
Yeah. Bradley, thank you so much for your time today, and I want to thank our attendees for joining us as well. A copy of the recording and the slide deck will be sent out to you after this event. Until our next event with EFEX Corporate and J2 Global, please stay safe and healthy.